First of all, we would like to introduce Dr. Kaz Thursky. She's an infectious diseases physician based at Peter Mac, as well as the NCAS director here, and has many appointments across both the university and the hospital, and everyone probably knows her very well. So without the interest of time, we'll open up to Kaz Thursky. Thank you so much.
Through the whole thing. Morning, everyone. As Rod said, I now know what to call myself. I didn't know what to call myself because I had so many hats, but I now officially call myself the infectious diseases physician, health services, and digital researcher. So that's what I do. But welcome everyone today. It was always Antimicrobial Awareness Week, so it's an interesting shift that it's been moved into Antimicrobial Resistance Awareness Week, because as you know, as antimicrobial stewards, a lot of what we do is actually about patient safety and patient outcomes, and that is across our health sectors, both animal and human. You will be hearing from experts, and today we wanted to be in person because this is an opportunity for networking, meeting people, and really uplifting you to be able to think about how you can promote your work. That could be learning how to communicate your work, also how to learn research skills. And today you'll be meeting many methodologists who I hope you can join with us. One of the things that NCAS wants to do is actually to create a research network that will allow us to uplift those colleagues of ours, both in Australia and internationally. And I'd specifically like to welcome the International Fleming Fund Fellows. Thank you, Susan, for all your organisation. It's lovely to have you here today. We will also actually have a high-level Indonesian delegation who's been in Melbourne this week looking at opportunities for research and clinical collaboration from 3 main hospitals, as well as the Ministry of Health, and they'll be here for some of the day. I'm not sure if they're here, but also welcoming our interstate colleagues. So thank you. I do acknowledge the challenge of flying in, but we thought it was a really important opportunity, particularly with some of the activities that we're going to be doing around design thinking, for it to be an in-person experience. So without further ado, I am going to show you our new logo. So this is our NCAS new logo, designed by our very own Shri, who's got a sore throat and is not here today. She's our graphic designer and user experience expert. This logo now represents better the One Health concept. It represents the collaborations that we have all over the world and in Australia. And it's a little bit more truer than the bright pink and the bright blue that was a little bit jarring. But anyway, we love it and we're very excited. Hope you are too. Before we start, I would actually like to acknowledge the traditional owners of the land, all of which these First Nations people had amazing medicines history, and we need to recognise their role in our nation, and we pay respect to their leaders, past and present. And we're on the Kulin Nation, but all of you have come from other areas as well. So I do like to show something that actually grounds the understanding of what the First Nations have brought to Australia. I've had so much fun now because with ChatGPT, I can put all these make images of everything. So this is a scale showing the challenge that stewards have. We face a challenge that, yes, we understand the threat of antimicrobial resistance, but on the flip side, we are dealing with sick patients with sepsis. We need to recognise that it's not a single focus here. It has to represent the fact that while we are creating stewardship programs, they need to actually put the patient in the centre first and foremost. And so I think recognising the two sides of the coin with stewardship at the get-go needs to be central to when we design programs. And for a long time, our team have talked about patient safety, that we're not antibiotic police, that it's a systems approach, that we need to have a patient-centred approach, and that everybody can be a steward. And we've been very fortunate and lucky to be working with our colleagues in animal health, some of you will hear from today, aged care, and even meeting people from the agricultural, both land and animals, livestock sectors. We need to recognise that there is an economic burden to antimicrobial resistance, and Norelle's going to be going into much more detail in her talk soon. But there's been some wonderful work done by Lisa Hall and her team, where they were able to look at the cost of 5 key pathogens. Many of you will recognise here, many of which you will recognise here, the challenges of treating. But to sort of put a figure onto it, it's important when we think about antimicrobial resistance, in order to get change, one of the things we need is actually a sense of urgency. Why is it important that we need investment in antimicrobial stewardship? At the moment, there is no financial incentive to any hospital or primary care network to actually do stewardship. There is one country that does it, and they were the top rated country for antimicrobial stewardship with a joint external evaluation. That was Japan. So Japan actually has incentive payments for hospitals to do antimicrobial stewardship and surveillance, which I think is an interesting point. But here you can see the association of premature deaths and cost to the healthcare system. When we're talking about, well, what antimicrobial resistance, we do know now that the WHO have a continuing updating, and this is the latest bacterial priority pathogens list. And really one of the focus that all of us have is around, obviously, carbapenem resistant pathogens. And we're actually very fortunate in Australia that we have quite low rates of them, but that doesn't preclude, and of course the high volume pathogens that we see still account for a large proportion of antimicrobial use, as well as inappropriate empiric use and directed use. I wanted to show you and again, Norelle will go into this in more detail, what is the magnitude of the problem that other people face compared to what we face? This is data from the EU, from their point prevalence survey of infections. And you can see in the light blue wedges, that is third generation cephalosporin resistance, and the dark blue wedges are carbapenem resistance. And then I've actually, put the staph and glycopeptide as well as, right, I should have changed that colour. But anyway, but I'm going to step you through the difference with what our colleagues in Europe are facing. And there are some countries which have very high rates and some have less. But you can see when we're starting to look at that bright blue wedge, the ceftriaxone resistance, it's really a lot less. And you can see particularly the dark blue, we're very fortunate that we are in an environment where carbapenem resistance in Australia is relatively low. And except for vancomycin resistance, of course, because we're world experts in generating enterococcus infections. We do know that there has been improvement over the last few years, but we also know that there are areas of antimicrobial resistance that we need to be focusing on, and aged care is really one area where we do need to be doing a lot more work. I also wanted to highlight some work. We have been working with NAPS for, we had our 10-year anniversary last year, and Norse, how many years is Norse? 20 years. In all that time, there had never been a direct comparison of consumption and appropriateness. It actually is very, very obvious that it's not just consumption, but we need to look at consumption and appropriateness. So Erin Connor, who's here today from Norse, did a beautiful job pulling together some data showing what that looks like. And here you can see very high use antimicrobials on the left-hand side, the beta-lactam inhibitor combinations, high amount of use with much lower appropriateness than perhaps the glycopeptides and carbapenems, which are typically used in a directed fashion or associated with clinical protocols, for example, with MRSA infections. And it is actually pleasing to see that even with fluoroquinolones, Australia has also been leading the world internationally, that we have not prioritised fluoroquinolones. For example, in our PEDMAC patients, we do not use fluoroquinolone prophylaxis, despite the fact that it's used widely. And so we can see that our antimicrobials of critical importance, I think, represent here that we have quite well, not perfect, but quite good use compared to the data from our international colleagues. The first generation cephalosporins, of course, part of our surgical prophylaxis guidelines. Here is when you start to unpick that into exactly what areas, and we of course land in the area of surgical prophylaxis, which we won't be talking about too much today, but might be one of the things you think about with your design thinking project. I've been, Rod and myself and Court and Laura and Ms Mediterranean have been invited to do a nature reviews paper on antimicrobial stewardship and the global status of it, which has been really interesting. And this was a paper that was looking at data from a WHO tripartite antimicrobial resistance self-assessment survey, and they looked at policy design, what was implemented, and what is being monitored and evaluated, and it was looked at in a One Health frame. And you can see what's represented there are median scores of all the scoring. There were over 50 metrics, and those that had minimum and those had maximal scores. And it's no surprise, actually, for you to see some of the challenges that our countries with lower scores have. And of course, you would recognise that in those countries, there are major issues around antimicrobial resistance and trying to build out the systems and WASH and healthcare infrastructures to actually build up the antimicrobial stewardship programs. And Rod and the WHO Collaborating Centre and the Fleming Fund Fellows are key to actually bring workforce capacity building in some of these areas, particularly in South Asia and the Pacific. So this is another ChatGPT generated image, and I asked it to say, show me the average day of an antimicrobial stewardship team when there's too much data, reports to write, patients everywhere, and this is what it came out. And why did it put an insect instead of a bacteria? It's really weird. But anyway, I hope that represents, and I also said I'll put lots of women as one of the things. I know. And so this is what it generated, but it's actually really challenging. A lot of us have been at it for a very long time, and now we understand very, very well that we need to be taking a considered and systems approach. One of the wonderful projects or programs that I've been involved with is Mark Davis, who's at Monash. He's a medical sociologist, actually. And we had a collaborative ARC discovery grant with him, and it was a qualitative piece of work where we interviewed patients, GPs, vets, and pet owners, and detailed, we've got oodles of data to look at. But what we wanted to create was a resource that you can use when you're doing your teaching, when you're doing your presentations, that there are wonderful stories in here from the vets, from GPs and patients. You can pull out quotes, you could use images. Please use this resource. I've got the QR code up there. But it really touched on a number of important themes, such as, how do we have that therapeutic relationship and trust that the doctor can address that issue about the patient asking for antimicrobials, the lived experience of what they went through. What are the business models that are driving antimicrobial prescribing in the community and how the doctors feel about that? Understanding the different identities and the psychological impact and also that risk and time. And we have got a paper that's out around the moral injury that many prescribers feel because they're being told not to prescribe, but they're really worried about their patients with sepsis. And that's again coming back to the fact that this is a real issue. We need to address the moral injury and make them feel safe that they can use antimicrobials when they need to. And this is a couple of stories. One, a GP talking about, working in a private practice where they're expected to push patients through, and Riley, who is a vet, and the discussions around, again, the challenge of knowing he's using these long-acting injectable antibiotics in a cat and the potential knowing that there may well be antimicrobial resistance associated with that. We are very fortunate in Australia. We're widely acknowledged as having one of the best healthcare systems in the world, but we cannot be complacent about that. And while we have wonderful quality of care, I don't need to tell any of you that we're very late, late in that health digitalisation, which is obviously a key area now. How can we use our data to drive knowledge? How are our EMR systems? Any of you who have some of the big EMR systems know they're not fit for purpose for exactly the sort of things that we do in antimicrobial stewardship. And it's challenging to get data out, and there's very little interoperability between community, primary and hospitals. And so we turn to what we call the learning health system. So I might get you to have a show of hands. Who has heard of the learning health system? Quite a lot of you. And it really is starting to become talked about in government and other policy initiatives. And the learning health system is a concept that was developed by Charles Friedman in the US. And we hear about high-performing learning health systems. And there are some explicit examples in the US, like the New York Langone. But really what it is in the applied learning health system is how do we put data at the centre of what we do, and patients, stakeholders, consumers, stewards. We need to come together as a learning health community when we go about implementing or developing something. And so we have in AMS, of course, one of the key things that we always talk about, well, what is the indication? If you don't know what the indication is, then how do you know what to do? So we are very cognizant of the fact, and this is what's driven the NAPS development in 10 years. We didn't know we were doing a learning health cycle, but we were. How can we collect meaningful data? How can we aggregate, analyse and present that data so that it becomes data for action, and so then allows you to develop your clinical pathways, your guidelines, decision support toolkits? How do you evaluate your outcomes? We will talk about that today, because all of us know it's very hard, and it's hard, resource intensive to understand how you evaluate your outcomes when sometimes it's really hard to get that data. And then how do we effectively communicate and feedback? And you may not be aware of this, but the evidence base around how to effectively audit and feedback, particularly in stewardship, is still challenging. Who do we feedback? What is it best to go to the CEO? To how do we do it to the prescriber? How do we, how do we do it? How do we do it best? We don't know. It's actually an area of interest for us. So just describing some of the activities that my team in guidance, as well as NCAS, has been doing, is really showcasing where we're at and the enormous opportunities, both for you to collaborate, but also to think about the programs that you might want to generate. And of course, we have pillars, what are the new models of stewardship, particularly working with the vets. They have done incredible work doing large-scale cluster randomised trials in veterinary clinics. We have the emerging personalised medicine. How do we implement, genomics and other biomarkers rapidly into our treatment pathways, and how does that work? Is there a cost-effective model that can happen when GPs only have 5 minutes with patients and to go out and consent them and do these tests? It's a real challenge. Digital health is huge, and obviously it's a central area for us, how to optimise our our data, delivery of programs, and that continuous improvement cycle. And then, of course, partnering with our consumers as researchers. And I think this is something that I'd really like to see. In the cancer space, with my cancer hat on, this is something that's actually pretty common. It'll be interesting to hear from you how that works with your stewardship programs. We have a number of amazing things happening. So Nolene Bennett, where are you, Nolene? Right up the back. She always sits at the back. Anyway, Nolene's leading an MRFF, which is establishing and bringing together infection and antimicrobial appropriateness surveillance in aged care. It's a really exciting program. And the aged care NAPS is actually done by over 1,000 aged care homes every year. Like, it's literally incredible how committed that sector is in actually working with us. Our early career research fellows have got an amazing and some of you will have been invited to be part of that, is a COMET program. We're doing an international consensus Delphi across One Health to try and get to a common understanding of appropriateness. What is antimicrobial appropriateness? There is no gold standard definition, but we need to come to some consensus so our policymakers and our farmers and our patients understand what we mean when we talk about that. And because it's actually a central pillar of every international antimicrobial resistance strategy. The NAPS is super exciting because we're actually undergoing a complete redesign led by Kaz Chen. New logo, new look and feel. It's up in the cloud now. We're bringing all the modules together. I think the first hospital NAPS will be released in around about May, June. And then the others will follow. And this has been a very important user-centred process, and many of you will have been involved in some of the validation studies of the matrix. I have the great fortune of being one of the investigators at Peter Mac in our Synergy program, and we've got a new CRE too. And we're really starting to step into that data science, both with our and MRIFF here, where we're looking at AMR data from hospitals, primary care and vets, seeing whether we can use natural language processing and machine learning to establish appropriateness. Really exciting, really focusing on urinary tract infections, pneumonia, skin and soft tissue. And then with NCAS, we've been doing NLP machine learning of EMR data, of histopathology, CT, PET scans, creating machine learning algorithms to help survey fungal infections, which are typically very difficult to find, rare, and often the surveying has always been done on a research framework. And then, of course, I have a great passion, as you know, about sepsis, and we're about to be releasing close to being done, our new Australian-New Zealand consensus guidelines for neutropenic fever. And for the first time, there is an entire chapter on antimicrobial stewardship and infection prevention in hemato-oncology, which is really exciting. We've not had that before. And Gemma Reynolds, I think, where are you? There she is, was involved in that. So, but ultimately, all of you work in teams. So one of the things I'd like you to take away is how can you create a high-performing team so that you can work together to actually do better in how you deliver it, but also how you can actually create research. And I've been very proud of my team. They're absolutely incredible that the work that we've been doing over all these years has helped to drive policy and practice, which is really the ultimate outcome for health services research. It's actually not about Nature papers and New England papers. We actually focus on patient outcomes. So this is our new CRE, and I'm just going to finish off describing to you what that looks like. And this was recently awarded, and we have some of the key people here. In the top, the CI, Glenn Browning, is our animal lead in NCAS, and Denise O'Connor, for those of you who know, is an amazing health services researcher in implementation science at Monash. Melissa Baysari is a professor of human factors, so you'll hear a lot about that today. Lisa Hall, Professor Lisa Hall, is our resident epidemiologist, and he'll be leading the workshop today. Nolene, of course, needs no introduction. Associate Professor Daniel Kupuro is a physician and informaticist with the Centre for Digital Transformation of Health and the Department of Computer Engineering. And Laura is our postdoc, one of our first PhDs in NCAS, Courtney, who will hopefully show her face with little baby Max. She's our postdoc who's had a focus in surgical. And then Leanne Teo, who is an amazing postdoc and dentist and pharmacist who's leading that work. And then we have important AIs who will help drive various aspects across the program. I just wanted to show you when we write grants, you know, the grantsmanship is a big, if you're going to become a researcher, some of it is around, unfortunately, just around grantsmanship and trying to show the grant reviewer, well, what have you done and what are you going to do? And why is this CRE different from the last CRE? And so this is something that we put into the grant. And you can see the questions we had for our first CRE, you know, back in 2014 or 2015. How are they prescribed? You know, can you measure appropriateness? Is there a national surveillance program? You know, what drives inappropriate use? What's our best practice framework in Australia? What interventions would fit the workflow? And that now obviously means the EMR workflows as well. And then what interventions actually work? And you can see the blue is what we thought we achieved quite well in the first, and in the yellow is what we're being addressed. And so a key component of that is recognising, as you say, when things fail, why is it? We need to take into account and use a design thinking approach to take into account the human factor issues and behavioural issues that might impact if that intervention is going to be successful or not. And implementation scientists are very important to understand what are the key factors that might lead an individual to behave in a certain way, the technology, culture, and other reasons that might make them do certain things, understanding the barriers and facilitators. The human factors overlap, but it's actually making sure that they understand the clinical ethnographic behaviours and the technology that's going to support them actually doing the thing. So I see it as a spectrum, often really not done. And when you see papers about successful interventions, they never talk about this. They'll talk about quantitative data about what happened. It's the silent bit that we will all know. And once you learn these things, it will make your ability to undertake stewardship much easier. So we have some programs looking at optimising audit feedback with the NAPS platform, optimising the surgical pathway, defining an AMS framework in aged care facilities. How can we scale dental, and can we do a dental NAPS? There's obviously there's a real movement in the dental domain now. What is a sustainable way for AMS in veterinary practices? Can we do a vet NAPS? Quite keen on these things. And then, of course, how can we bring together data in the livestock industry to actually glean information about knowledge awareness and bringing some stewardship down to at the farmer level, who are the ones who are often giving the antimicrobials to the animals. So we are actually have some expressions of interest around positions. So there'll be 3 PhDs that will be working within NCAS. We'll also have co-supervised PhDs with Monash University, an implementation science PhD. I know that is definitely of interest to some of you. And also with Melissa Basaria, co-supervised human factors, which is really exciting to really start to get some expertise in that. And that comes with stipend. It's a secured stipend. And so we're going to be also looking at postdoc roles in surgical, aged care, veterinary, dentistry, and a combined human factors. So if you're interested, please contact Leslie, I'll catch up with her during the day. Where are you, Leslie? Right at the very back. Please just say hello to her. And also, we made a decision a couple of weeks ago to move off Twitter or X for obvious reasons. And so we've moved across to Blue Sky, and it's actually really lovely. It's a very friendly platform. There are a lot of packs, ID and AMS packs you can click on straight away to join large groups. It's sort of, there's been a big shift of medical journals and everything in the last week since the US election. And we're also now on LinkedIn, which is a really nice way to connect. So if you're wanting interpersonal connections, definitely use LinkedIn. All of us are both active on not only our site, but our individual sites. So please do. And then, of course, we are going to refresh the website, but on that website is a huge amount of information, resources, webinars, training packages, and things like that. So I'm going to stop there. I'm really looking forward to the day. I really do hope that you use this as an opportunity to meet people, collaborate, and do some learning that you can take back to your own organisations. We are very cognizant of the difference between Australia and our colleagues from lower middle income countries, but we also understand that many of the principles that we're talking about today also apply, because you need to take into account your resources. So I'm probably over-talked again, but no? All right. That's good. Thumbs up from my team, because I've always talked too much. All right.
Thank you so much, Kaz, and thank you for the first time for getting 2 times. That's very exciting. And I'd like to welcome our second speaker, Associate Professor Norelle Sherry, is a medical microbiologist and infectious diseases physician, and based here at the Doherty, and Deputy Director of the MDU Public Health Laboratory here, and her research interests focus on AMR, genomic implementation, and clinical and public health microbiology. So thank you so much, Norelle.
Great. Thanks very much, Rod. And to my co-lead of the AMR theme here at the Doherty. Thanks, everyone. It's really nice to be here today and good to see you all. So why is a microbiologist here talking about AMR to an AMS audience? Well, I guess from my point of view, I think that the knowledge of AMR and what's happening both here, but also broader, what's happening in the region, what's happening internationally. I think this is really important knowledge. And this is actually essential, I think, to lead into guidelines and also understanding individual cases and individual situations. And I'm on ward service at the moment, and as I tell my registrars, and the pharmacists as well, it's really important to know what's happening in the lab and speak to the lab. Quite a few of my former registrars here as well, so that's great, good to see. So hopefully I can give you an overview of what's happening with priority pathogens here in Australia and a bit of a global view and an eye on what's coming, what am I losing sleep over? Okay, so I'll start just looking broadly at the Western Pacific region, priority pathogens, and also a couple of the issues limiting AMR surveillance that are relevant for a clinical audience. Don't worry, I won't be talking about laboratory stuff too much, and seeing what's coming. So this really interesting report came out from the WHO Western Pacific Region Office, and those of you who don't know, we are in the Western Pacific region. So there's kind of a Southeast Asia region and Western Pacific, which kind of splits everything around us in half. But these are the countries that are covered there, and so it gave some great estimates on both mortality and economic burdens for the Western Pacific region countries. And it's quite interesting when you look at this in detail. So the burden is not spread evenly as I guess we'd expect. And to the whole region, there's such a huge burden, but you can see that countries of different sizes bear that differently. So a massive projected mortality rates in China, but you can see they're also not proportional. So if we have a look at the Pacific Island countries and PNG, their mortality rates are projected to be much greater than Australia, even though their populations are much smaller. So I guess the bottom line of this is that mortality is significant from AMR, projected and actual, and it's not spread proportionally. And we've seen the same thing with economic burden. And so the total projected economic burden of AMR in the Western Pacific region, so not globally, but just the Western Pacific region over these 10 years, it's projected at $148 billion US. And just in Australia, $6.1 billion over 10 years, and that's enormous. And similarly, that burden is not borne evenly across the region. So a lot more burden in the low and middle income countries and resource limited settings. Okay. So Kaz gave a lovely introduction to a lot of what I'm going to talk about, so that's great. So this is the recently updated list of WHO priority pathogens. And I'll actually go through most of these in more detail. So there's the critical group, and there's the high group and the medium group. And the medium's kind of more focused on pathogens in the community and things that are emerging there. And the critical and high risk groups are a mix of healthcare associated infections, but also enteric infections. And so some of these are not hugely relevant in Australia, but still things we need to be aware of. And then down in the bottom left corner is drug-resistant TB, which didn't quite fit into all of those, but it is definitely a very significant priority pathogen globally in terms of AMR. All right, so just a very brief overview of AMR surveillance in Australia. I think the bottom line would be to say that there is no single surveillance system that covers all AMR pathogens and mechanisms, and this is true in all countries and globally as well. So in Australia, we have AURA, which is the Antimicrobial Use and Resistance Australia, I think, with a focus on patients and hospitals in general. It's funded by the Commonwealth through the Commission for Safety and Quality in Healthcare. And in terms of the AMR surveillance, it includes multiple programs. So there's a car alert program that where labs submit isolate level data for these critically resistant AMR pathogens. There's AGAR, the Australian Group for Antimicrobial Resistance, which does surveys of about 35 hospitals around the country, not evenly spread, unfortunately, where they only look at bloodstream infections where we know they're actually significant, and they collect a lot of great clinical data as well and focus on those pathogens here, a lot of which are in the priority pathogens group. I'll be showing quite a bit of their data from their annual reports just to give that overview of what we're seeing in Australia. And there's also some passive surveillance getting just laboratory data from select laboratories. Again, that's not spread evenly. And then in terms of state and territory level AMR data, so this is focused on notifiable organisms that are public health significance. But there's a really significant variation in Australia in how our health departments think about AMR. Some of them don't want to know about it. Fortunately, I know in Victoria, we've got a very progressive health department who's been onto AMR from the beginning. And so we actually have pathogens that are primarily notifiable because of their AMR status. And something I didn't know before getting into public health was it's actually very hard to collect AMR data on a pathogen that's already notifiable for another reason, like Shigella or Salmonella. And so that is a challenge that we're looking at nationally at the moment. And there are also some emerging AMR pathogens and problems that aren't well covered by any of these existing surveillance systems. And I'll talk about some of these a little bit later, but Mycoplasma genitalium is one of them. All right. So in terms of AMR and gram-negative pathogens, there's a few different terms that are important. So we talk about enterobacterales. So these are the enteric gram-negatives, and the main resistance mechanisms are the extended spectrum beta-lactamases, or ESBLs, characterized by resistance to third-generation cephalosporins like ceftriaxone, as well as carbapenems, or CRE. And then there's also some additional resistance worries within Salmonella, particularly fluoroquinolones, and Shigella as well. And then there's these other non-enterobacterales. We've got Acinetobacter baumannii, that's carbapenem resistance. This is in terms of the WHO priority pathogens. Pseudomonas also carbapenem resistance. And then slightly to the side is Haemophilus influenzae, which is also a gram-negative and emerging resistance to ampicillin. The naming is very confusing, so I hope this helps some of you because I know it did help me early on. So anything with a CR in the front is usually carbapenem resistance. Anything with a CP in the front is a carbapenemase producing. So that's an enzyme that chews up carbapenems, and ESBLs in there as well. Okay. So carbapenem resistant enterobacterales right up there in the critical resistance list. These are a huge problem globally. So they're multi-drug resistant pathogens. So although these are defined by their carbapenem resistance, these are usually multi-drug resistant. So these big plasmids, collection of resistance genes to different antimicrobials are swapped freely between different enterobacterales in the environment, in your gut, especially in hospitals. It can be any species of enterobacterales, but they're mainly in E. coli and Klebsiella because these are the most common enterobacterales infections in humans, and in fact, some of the most common infections. Mainly in hospitalized patients, but we are seeing them increasingly in the community, and this is what we're seeing as the pattern more broadly internationally. And it's a particular worry when these carbapenemases get into E. coli and get fixed in E. coli, because one of the greatest burdens of infection are E. coli UTIs in the community. So whilst, Klebsiella are primarily hospital pathogens in terms of this resistance, It's actually the E. coli that I worry about more on a kind of population level. And these are characterized by long-term gastrointestinal colonization and shedding. So once you've got it, you've probably got it for life. Not that that's entirely true, but in most cases it is. And because of this long-term colonization and shedding, hospital outbreaks can be really severe and prolonged. So as the resistance mechanisms, we're talking about carbapenemase enzymes, and these are, we worry about the most because they are swapped around and they're what leads to a lot of transmission and outbreaks, particularly in hospitals. And the example of those are KPC enzymes, NDMs. They're probably the biggest problem now globally, as well as OXs, and then some less common ones. And carbapenem resistance can also be due to other mechanisms, particularly in Klebsiella and Enterobacter, so mutations in the porins, so carbapenems can't get in, or efflux pumps, so carbapenems get pumped out. So carbapenem-resistant E. coli is low in Australia, but it is increasing. So this is data from the AGAR 2022 survey that's recently been published. And so you can see overall Australia's carbapenem-resistant E. coli prevalence in bloodstream infections, important to note that, was 0.08%, so tiny. And this is where we want to be, right? This is where we want to be. We want to keep it like that. You compare that, the data on the right, so I'm going to be showing some of these maps again. So this is data from EARSnet, so an ECDC European survey of AMR, so particular pathogens. And so these are comparable because they've both got similar methods. This is why I'm putting that up. So the carbapenem resistance in E. coli, relatively low. That's usually in the 2 to 5% in that kind of yellow color. A couple of countries here, particularly Greece, with higher levels of resistance. Keep that in mind, though, when we look at Klebsiella, it's a very different situation. So on the right, we look at the European data. This is not where we want to be. So very, very high rates. So in Greece, more than 50% of their Klebsiellas are bloodstream infection are carbapenem resistant. That's a disaster. You know, that's the kind of level when we talk about, okay, can we still do transplants and can we still offer surgery? This is really, really difficult. And it's not just Greece. There are multiple other countries there. Again, in Australia, our rates are relatively low and we want to keep it there. But the bloodstream infection data is just the tip of the iceberg, unfortunately. So this is Victorian data that's publicly available, only going up to 2021, sorry, but it's a very similar situation post-COVID. We have hundreds of notifications per year because we're looking not just at bloodstream data, but also at non-sterile sites and colonization. So if you're talking about transmission and being a kind of a source for someone else's infection, then all CPE are important, all CRE are important. So the bloodstream infections are only a really tiny percentage of those cases. So even though we can't see it in the AGAR data, we know there are carbapenemase producing Enterobacterales circulating here. All right, so moving on to carbapenem-resistant Acinetobacter. So it's very different pathogen. So it's environmental gram-negative. It's opportunistic. It's mostly in hospitalised patients, usually in ICUs and burns patients. You get transient colonisation of the skin and mostly associated with ventilator-associated pneumonia, CLABSIs, bacteremias, but it might be implicated in some mixed flora infection. It's transmitted from the environment, but also person to person, and it's really sticky. It's good at sticking to the hospital environment. The resistance mechanism for carbapenem resistance is usually an OXA23 carbapenemase, which is born on a plasmid and again swapped around in the environment. But this is on top of significant intrinsic resistance. So if you add an OXA23 on top of an Acinetobacter, your treatment options are very, very limited. So again, we have really low prevalence in Australia. So I'm about to show you the rest of the map, but in Australia, we have 3% of our Acinetobacter baumannii bloodstream infections were carbapenem resistant in agar in 2022. But this is what we're seeing globally. And the threat is on our doorstep. So particularly through Asia and Southeast Asia, the rates of carbapenem resistance are incredible. And some of them are well over 50%. I visited Indonesia recently, and I think their estimated carbapenem resistance in Acinetobacter in ICU was 80% or more. So that's a disaster in ICU. And so this is what we need to prevent and what we need to look out for. All right. Similarly, carbapenem-resistant Pseudomonas, it's a little bit different. So still an environmental gram-negative and an opportunistic pathogen, really lacks the lungs if you don't have normal lungs. You get pneumonia, hospital-acquired pneumonia or ventilator-associated pneumonia, chronic lung infections, but can also cause skin and soft tissue infections. Again, transmitted from the environment and person to person, really lacks water and SIX. And the resistance mechanisms are a bit broader. So there's carbapenemase, but there's a lot of non-carbapenemases as well. So porin mutations and efflux pumps. So these are usually resistance that's developed within a patient rather than transmitted. And you can have carbapenem resistance, but still be susceptible to other beta-lactams via some of these porin and other mutations. So that's quite a saving grace, I think. In Australia, our prevalence is rather low, about 4.3% overall in 2022. Again, very, very high rates in Europe. And you can see, those of you who I guess have seen some of the antimicrobial consumption data in other countries, you can see the countries there are very, very high up on those lists. Chicken or egg, I'm sure you guys can discuss that further at lunch. All right, stepping down a little bit in terms of how critical the resistance is, are extended spectrum beta-lactamases or ESBLs. These are our ceftriaxone and other beta-lactam resistant gram-negatives that are annoying, but not quite as problematic in hospitals. There's two main classes, the AMP-Cs that might be susceptible to cefepime and ESBLs that are resistant to cefepime. They're globally distributed, they're increasing. They're now getting into enteric pathogens, which is a real problem in low and middle income countries in particular. Salmonella, non-typhoidal salmonella and typhoid, and Shigella and others. Often carried on multi-drug resistant plasmids as well. So not only do you knock out your cephalosporins and your narrow spectrum beta-lactamases, but you also often knock out your quinolones and your aminoglycosides and probably your Bactrim for good measure. And all of a sudden you end up with a pathogen that has no oral options. And so this is where we end up with kids with community-associated UTIs with no oral options. It's a disaster, right? It's really, really difficult. And on the other hand, we end up with these complex multi-drug resistant pathogens in healthcare. So an ESBL on top of an intrinsic AMP-C and escapum organism, and you end up with very few things to treat with. There's also the things like the Merino trial that has showed that, you can't use piptaz for these in severe infections. You need to use meropenem. So again, we're going with more and more broad spectrum antibiotics. And so the rates in Australia, I think because we're looking at bloodstream data, this is underselling the amount of, or the burden of disease in Australia. The rates vary a lot between the different states and territories. I would just put a kind of asterisk over the Northern Territory data because their numbers are very low and very hospital-based. But even though the prevalence is relatively low compared to internationally, if we have the high burden of disease, both invasive and non-invasive, and multi-drug resistant strains, it means that we have a huge burden of AMR across a population and additional broad spectrum antimicrobial use. All right, switching over to the gram-positives. So VRE, as Kaz said, we're really good at growing VRE in Australia. So enterococci, normal enteric flora, they can be opportunistic pathogens, particularly in healthcare settings. Again, prolonged GI colonization and shedding, and they're usually acquired in the hospital setting from the environment or shared patient equipment. And it's about acquiring VAN A or VAN B genes. It means the vancomycin can't bind to cell walls. They're more common in Enterococcus faecium than Enterococcus faecalis. And Enterococcus faecium, again, already has greater intrinsic resistance. So you end up with very few options for treatment. Okay, and so this is not as green and lovely as some of the other pathogens. So we have a lot of VRE in Australia, and this was just in bloodstream infections, so not taking into account colonisation even. I think if we took into account colonisation rates, we would be right up the very high end of the scale in probably most of the states and territories. And so we're actually fairly similar to Europe and a lot worse than a lot of the European countries in terms of resistance here. And so there has been this tug of war between VAN A and VAN B. So this is looking back at 10 years of agar bloodstream infection data. So the VAN B is the dark blue and the VAN A is the red. And why does that matter? Okay, with VAN B, you've got lower vancomycin MICs, you've got teicoplanin susceptible. With VAN A, is teicoplanin resistant. So that essentially leaves you with linezolid, daptomycin, and maybe tigecycline if it's not a bloodstream infection. But there are different different patterns in the different states and territories, and they actually vary over time. So it looks like VAN A went up mostly in New South Wales, but seems to be coming down now as a proportion of what we're seeing. But this is one of the things that keeps me up at night. So emerging resistance to daptomycin and linezolid. So if we have a truckload of VAN A VRE, and then we knock off linezolid and we knock off daptomycin, we're in very big trouble. So in Victoria, we have an ongoing outbreak of linezolid resistant VAN A VRE, and some of those are daptomycin intermediate and resistant, so also very concerning. And a paper that's just come out from our laboratory after about 5 years of work, as well as from the Austin, is about rifaximin prophylaxis causing daptomycin resistance. And so that's a very interesting read if anybody wants to look at that. So yeah, what's the association between using rifaximin and then getting resistant to a completely different antibiotic? And that's all about changes in the cell wall. All right, MRSA. So MRSA was the big news 10, 15, 20 years ago. That was what we were all talking about for AMR. So major cause of skin and soft tissue infections, and this crosses the community and the hospital divide. So initially started as a healthcare associated pathogen, and then we had these community strains as well, and they used to be very different and there was less resistance in the community strains. Now they're all intermixed, so you can't tell what kind of pattern you're going to get, whether you're in the community or in the hospital. Strangely, MRSA and actually Staph aureus bloodstream infection rates have been decreasing globally for the last 5 years or so. I haven't had anyone actually properly been able to tell me why that is, but it's a good thing anyway. But I think it's also something that varies a lot locally, and it's important to understand your local MRSA rates so that you can inform your empiric treatment guidelines. So do you need to actually add vancomycin to the sick patient in ICU? Well, if your MRSA rates are very low, then you can stop doing that, or at least try stopping your ICU doctors from doing that. These are our rates. It's about 15% overall. It does vary a lot between the states and territories. And it looks like actually some of the resistance to other antimicrobials are decreasing over the last 10 years. So here you can see the erythromycin, clindamycin, and sulfamethoxazole rates decreasing there. So that's good news, I think. Just some brief notes on some community pathogens. So if we're working in hospitals, we don't always get a lot of information about these. But strep pneumo, we're looking at macrolide resistance and beta-lactam resistance emerging. Group A strep, macrolide resistance. Fortunately, Group A strep seen entirely incapable of developing beta-lactam resistance, which is really good for us, I think. However, group B strep or strep agalactiae, which is a pathogen that can cause neonatal meningitis and UTIs, there's emerging resistance to penicillin, and this is uncommon currently, but it certainly does occur. And the mainstay of treatment is penicillin, and so pregnant women are given prophylaxis just before they give birth, but most labs don't actually screen for penicillin resistance. So this is something we need to, as well as macrolide resistance. So this is something that I think needs to be looked at further. And Haemophilus influenzae, a range of different beta-lactam resistance emerging, as well as macrolides. And the STIs, again, in the hospital, we don't hear about this a lot, but Neisseria gonorrhea, ceftriaxone and azithromycin resistance is also keeping me up at night. So there are extremely high rates of ceftriaxone resistance in Asia. There's limited data, but the data that we do have say there's about 30 to 50% ceftriaxone resistance, which is completely unfathomable for what we've got here. We're at the well below a couple of percent. And interestingly, we're seeing this more in the heterosexual community in Australia. So we're starting to see imported cases. And it means so a lot of the gonorrhea and STI avoidance messaging has been to the MSM community. And so we need to start thinking differently about that. And the problem here is that we're going to see treatment failures, particularly with pharyngeal infections that are really difficult to treat. But our surveillance is not complete. So we're going to be missing those. And there are limited alternative treatments. There's also Mycoplasma genitalium, which is a cause of non-gonococcal urethritis, probably only recently kind of identified and routinely tested for in sexual health. So they have very high resistance rates, particularly to macrolides that are the principal treatment, and now also to quinolones. And the diagnosis is by PCR, but not until recently are there actually resistance PCR testing available. And Shigella. So Shigella is one of these weird bugs that's an AMR pathogen. It's an enteric and foodborne pathogen, but hey, it's also an STI. So it can be an STI, particularly in the MSM population. In Victoria and New South Wales, we have high rates of drug-resistant, of ESBL producing Shigella, but we're now seeing them elsewhere. And so we're actually adding AMR surveillance into the Shigella series of national guidelines so we can get some data to look at it nationally. I won't talk much about drug-resistant tuberculosis. That's a whole other talk. Really significant issue globally. Low but increasing rates in Australia, almost all imported and difficult to treat. Very briefly, some challenges in AMR surveillance. A lot of the diagnosis now is being done by PCR, so we don't have cultures to do the proper microbiological surveillance on. So this is a big challenge that we are facing. So gonorrhea is a key one there, where almost all the diagnosis is by PCR, and so we have to rely on a few very diligent clinicians to keep ordering gonopathogens. So a message to the clinicians here, please order gonocultures when you're doing an STI screen or when they're PCR positive. We need to move to metagenomics, but the technology is not quite there yet. Resources are a big issue, and here it's worth thinking creatively about alternative methods like snapshot surveys. We're looking at either a period of time, at a location or a patient population, rather than the kind of daunting task of setting up a continuous surveillance mechanism. So that's something that's gaining popularity. Things like wastewater surveillance, although I'm not convinced it's going to be particularly fit for purpose for AMR, and maybe some other environmental surveillance. And then data connectivity is a huge issue in AMR as well. So we really need to integrate epidemiologic data, clinic data, laboratory data, and One Health data to really understand the problem. So in summary, AMR is important on a patient, a hospital, and a societal level. Rates are generally increasing. Australia is pretty well placed currently, but we really need to be vigilant to ensure we stay like that. Understand your local and national AMR patterns to inform patient management, especially when you think about empiric treatment. Be aware of some of these emerging risk pathogens, especially when patients have travelled. And clinicians and pharmacists, of course, play a really important role in AMR surveillance, cultures, and metagenomics in the near future. And we need comprehensive and integrated AMR data to enable us to appropriately identify and respond to AMR threats. Thanks very much.
Thanks, Norelle, for that amazingly detailed talk. I just want to make it clear that also all the talks are being recorded and they will be available on the NCAS website. So if you do miss anything and you want to go back, they will be available. But thank you so much, Norelle. Probably won't have too much time for questions, but if our speakers are around during lunch and morning teas, you can ask them a few more questions. But in the interest of time, we will move on to our next speaker, who is Ms Misha Devchand, is an infectious diseases antimicrobial stewardship pharmacist with extensive experience in designing and implementing new AMS services. She is the project lead for Check Again Network, which is the Safer Care Victoria initiative, and a senior in infectious diseases AMS pharmacist at the Austin Health. So thank you, Misha, for your time today.
Thank you. Awesome. Thank you. So today I'm going to be presenting on the Check Again network. So this is a statewide project to scale penicillin allergy assessment and delabelling to Victorian hospitals. I wanted to quickly start with an acknowledgement of country. So Safer Care Victoria acknowledges the strength, power and resilience of Aboriginal people as members of the world's oldest living culture. We recognise Aboriginal people as Australia's first people and honour the richness and diversity of all traditional owners across Victoria. We pay our deepest respects to ancestors, elders and leaders, past and present, whose strength and fortitude have paved the way for future generations. So a quick overview of my presentation today. So really, we're going with this audience. I don't need to tell you why we focused on penicillin allergies, but I will give you a quick overview. And then I'm going to be talking about the evolution of the project Check Again. So where we've been, where we currently are at, so that's the Check Again network. And then I'm also going to briefly touch on some of the learnings we've had throughout the lifespan of this project for other AMS programs. So why penicillin allergies? For more than 90% of patients with a penicillin allergy, these allergy labels are inaccurate and they can be removed with a thorough allergy assessment and or allergy testing. So we know that antibiotic allergy labels are associated with the wrong antibiotic. So they're associated with the overuse of broad-spectrum antimicrobials. We know that patients with an antibiotic allergy label spend more time in hospital, so they have increased length of stay and increased readmission rates. Patients with an antibiotic allergy label actually have worse health outcomes, so they have higher mortality rates and they're more likely to get an infection post a surgical procedure. And they're more likely to have infections with multi-drug resistant organisms and also be colonised with multi-drug resistant organisms. So that's things like MRSA, VRE, and they're also more likely to have infections with C. diff. I just wanted to remind you all about the Commission's antimicrobial stewardship clinical care standard. So quality statement 3 actually relates to the documentation of adverse reactions to antimicrobials. So it is something that all Victorian health services are looking at the moment. This clinical care standard really talks about ensuring that our patients have comprehensive documentation of their antibiotic allergies while in hospital. So the evolution of Check Again. So Check Again started in 2019. It wasn't called Check Again at that point, but it was actually a BCV innovation grant that was obtained by Professor Jason Tribbiano. And it looked at 2 sites in particular. So it looked at the Austin Health and Peter MacCallum Cancer Centre. The aim of the initial project was to identify low-risk patients reporting a penicillin allergy that can undergo successful oral challenge utilising a published protocol or direct removal of an allergy from the record in the setting of a known reported side effect. From this project, I've got the reference down the bottom there, but we've got some great published outcomes if you haven't read that paper. And from there, in 2021, Safer Care Victoria, in conjunction with Department of Health, launched the 100,000 Lives program. So the 100,000 Lives program was had the aim to reduce harm and improve health outcomes for 100,000 Victorians by June 2026. And based on the results of that 2019 project with the Austin Health and Peter MacCallum Cancer Centre, they engaged with Professor Jason Tribbiano again to be involved in the 100,000 Lives program. And that's how the Check Again Collaborative effectively came about. So in 2022, the Check Again Collaborative was launched. The aim of the Check Again Collaborative was really to develop different models of care to assess and delabel low-risk penicillin allergies for hospitalised Victorians. And that leads to now. So now we're 2024 and we now have the Check Again network. I'll go into that in a little more detail later on, but the aim of the Check Again network is by December 2025, more than 25% of public health services in Victoria will have implemented a penicillin allergy assessment and delabelling program to ensure more Victorians have access to the safest, most appropriate antimicrobials. I wanted to start this presentation really with some reflections we had from some of our consumers who were involved in the first stage, in the collaborative phase of the project. So we had lots of positive consumer feedback and consumer stories. One of our consumers said that they liked the way they discussed, so they being the clinicians, discussed how they would test in a controlled environment, knowing you were totally safe. Their professionalism and informative manner were brilliant. Our second consumer was actually a couple, and they said that this program changed our lives. We no longer need to worry about this penicillin allergy. And then our last consumer said, I was receiving the second best drug. Penicillin was more effective than the drug they were giving me. So we had a really overall very positive response from consumers for this program. So the Check Again Collaborative. The Check Again Collaborative ran from 2022 to 2023. We had 12 health services across Victoria who participated. 8 of those were metropolitan sites and 4 of those were rural regional health services. We had quite a mixed bag of project leads. They were a majority of AMS pharmacists, but we did also have allergy pharmacists, nurses, medication safety pharmacists, and then a manager of development and improvement leading that project at a health service level. So in terms of the approach that we used what's called a Breakthrough Series collaborative model. And so this is a model that we partnered with the Institute for Healthcare Improvement, so the IHI, to roll out essentially Victoria-wide with our 12 health services. So this approach really aims to bring research to practice. So this is an improvement model, and it relies on the spread and adaptation of existing knowledge to multiple settings to accomplish a common aim. Now you'll see that it's quite an intensive program. So you have learning sessions, and in between learning sessions, health services go back to their health service and really undertake these rapid Plan, Do, Study, Act or PDSA cycles to result in improvement in their local system. And you can see that the program itself only went for 10 months. So it's quite a short program, but really very intensive. So what did it look like from a health service perspective? So as I mentioned, Jason Tribbiano was involved throughout the project, but this was the way that he spoke about this to our health services. So the health services could either have a plain burger, so, just a patty by itself, or they could have multiple levels in their burger. So they could include cheese and beetroot and, whatever they wanted. And this is what it looked like for them. So we really said that assessment was that plain burger by itself. So we expected all health services to implement that model, so that really comprehensive documentation of penicillin allergies. In terms of whether they chose to add a direct delabelling component, so a direct delabelling component is the removal of a penicillin allergy based on history alone. That was up to the health service, and then they could also choose to implement an oral challenge component. And an oral challenge component was when the patient was assessed as having a low-risk penicillin allergy and then underwent a test dose of penicillin as an inpatient. We did keep skin testing outside of the scope of this program. So in terms of the overall results of the Check Again Collaborative, so all 12 health services implemented processes to improve penicillin allergy assessment and documentation. 5 sites improved allergy documentation by greater than 30%, and 3 sites improved allergy documentation by greater than 70%. 10 health services implemented an oral challenge protocol. And by the 31st of August 2023, 11 health services had safely undertaken at least one oral challenge. I think it's really important to note that during the lifespan of the collaborative, there was 0 adverse events seen from the oral challenges that were undertaken. I wanted to highlight the models of care used by our teams in the collaborative. So you'll see that most of our teams used quite a multidisciplinary approach. And we think that was a really important and quite a brave thing to do in this sort of system, but it was something that was really necessary for our project. So it was really important to have key engagement from your stakeholders. And we really found at the end of the program that sites with AMS involvement, pharmacy involvement, infectious diseases involvement, and nursing involvement really were those most successful sites. And the sites that didn't have them initially started to obtain them throughout the course of the collaborative. So the strengths of the Check Again collaborative. So we learnt a lot from the Check Again collaborative. Our sites were amazing. Their level of engagement was phenomenal. They were all really passionate about this project. We had a really engaged steering committee. We actually called them the faculty because the IHI is from America and they call them the faculty. And so our faculty was we had a group of clinicians and consumers who were really important to drive this work, and their enthusiasm was really something that really assisted us with this project. Our sites really enjoyed the fact that we were sharing resources. So we were sharing protocols, we were sharing guidelines. We were also sharing models of care. So what does this look like at different hospitals around Victoria? Collaboration was one of the great strengths. So sites really were able to get together, collaborate, learn from each other, share their wins, share their challenges, and ask for advice, which was really important. And then we had a strong education component. So the education component did include some improvement science education, as well as antibiotic allergy education. In terms of the challenges we had with the collaborative, as I said, it was an intensive program. It did require a lot of time from our sites, and our sites really struggled with that. The duration of the collaborative was 10 months. For our hospitals, so that we're talking about Victoria, right? So all of our health services had to get protocols approved individually. That took a majority of health services 8 months to do. So in a 10-month collaborative, they spent 8 months trying to get their protocols approved internally. So that wasn't a great timeline. In terms of our data collection and platform, this was rolled out as an improvement project. So we did ask for quite a bit of data, and our sites really, really struggled with that. And they struggled with the platform we were using. We were using a different platform. Nobody had used it before. It meant there was another login that people had to remember. Our sites really struggled with that. And then also, so this was just out of COVID. So right at the end of the pandemic, when we were just rolling back into what does COVID normal look like? And so whenever there were spikes in COVID, we really saw that engagement from our sites really drop off, and that was unavoidable at the time. So our key lessons from the collaborative were engaging with teams. So we needed short, sharp sessions. They needed to be clinically relevant. We found when we used abstract examples, we really lost our teams, and that's something that we learned quite early on. We needed to streamline our improvement science teaching. We have to remember that a lot of our clinicians were from a research background, so improvement science was really new to them. And I think initially that the difference between research and improvement science was not always apparent, and that made things quite challenging. And we found that our sites loved the sharing and the learning from other teams. What else we found? So governance, we really found to successfully implement this program needed to be multidisciplinary. We needed pharmacy leadership involved. We needed infectious disease leadership involved. We also needed hospital executive support, particularly nursing executive support is really important in a program like this. The models of care. So we really learnt, all of our sites had a different model of care, and that was successful. They learnt from each other. They adapted models of care that were working in other services, but really having that multidisciplinary model of care was really important. And we're really lucky in Victoria that most of the AMS teams have that already set up. So it's just something to leverage when rolling out a program like this. We learnt we needed data that was easy to collect. It was relevant. Clinicians could see the benefits from that data, and it really needed to be like a minimal time burden for people to collect that data. So that takes us to the Check Again network. So the Check Again network has been established this year. The Check Again network is really based off what we learnt from the collaborative. So the Check Again network effectively is, it's a merge between a learning health network, a breakthrough series collaborative model, and then a community of practice. So we've sort of taken all of the aspects that we know our clinicians like and merged them together to form the Check Again network. The pillars of the Check Again network are collaboration and learning from each other, which we know that our sites really enjoy, and that's really where they found the most benefit. We have a networking component of the network, again, to enhance that engagement from our sites and really enhance that collaboration. We, of course, have an education component, and we have a real strong focus on how do we educate our clinicians. And then we have an advocacy component. So how do we look at this, in a bigger scale? How are we looking at system-wide problems that are affecting our health services, and what can we do about those? In terms of partnership, we have formed a partnership with the International Network of Antibiotic Allergy Nations. And some great points about this partnership are that it demonstrates Safer Care Victoria partnering with clinical academia. With this network model, we are actually leveraging the data that INAN is currently collecting, which means our health services don't need to collect additional data to be part of the network, and they are using data that they are already collecting. We're using a partner who's looking at health service reporting, audit and feedback, as well as implementation on a larger scale. And we're also working together on some of the advocacy opportunities. So this is the Check Again network team. I just wanted to really highlight that there are a lot of people involved in the network. We definitely wouldn't be where we are without our clinical lead, Professor Jason Tribbiano, but we do have a lot of support, particularly from the Institute for Healthcare Improvement as well. We also have an amazing steering committee who are involved in the network, and they're really helping to drive what we do with the network, drive our education component of the network. You can see here, we've got a mixture of clinicians as well as consumers on that. And again, it's a multidisciplinary steering committee, as we really think that is one of your enablers for success. So I'm just going to revisit the aim of the Check Again network. So that was by December 2025, more than 25% of public health services in Victoria will have implemented a penicillin allergy assessment and delabelling program to ensure more Victorians have access to the safest and most appropriate antibiotics. So we currently have 20 Victorian health services involved. We are ongoing with our recruitment, so we're hoping to get more. If we manage to roll out penicillin allergy assessment and delabelling at all 20 health services, we will have achieved our aim. So we've actually gotten there a lot faster in the project's lifespan than we thought we would. We had our first in-person collaboration day in August this year, and some of the feedback we got from our health services were, honestly, I'm so impressed with it. I don't have any feedback. Meeting regularly allows for a check-in, but also continues to foster motivation. And one of our participants really enjoyed the ability to cross-pollinate and share ideas. So far, we've had overwhelmingly positive feedback about this network model. So this is the lifespan of the network. It happens every time I show this slide, I need to change it. We have our virtual meeting, which is next week, is actually our first virtual meeting for the network. It's going to be a great session. We do have an immunologist coming and talking about allergy mimics. We've also got one of our allergy AMS nurses who's going to be presenting on education, particularly looking at nursing staff and allied health staff and how she did that at her health service. And then again, lots of opportunities for discussion, learning from each other and sharing during that session. At this stage, the current phase of the network is anticipated to end in December 2026, but we're hopeful that it will continue just probably in a lighter phase than what it is now to help continue this work. So I really wanted to touch on learnings from other AMS programs. So what we learnt really was consumers. So consumers were, our health services found it really tricky to engage with consumers. And it was really interesting to me that most of these projects were set up by AMS teams, but a majority of them had never engaged with a consumer before. which was really interesting. So we really had to mentor them and really tell them, you know, you've got access to consumers locally. This is what that could look like, and this is how you work with consumers. They are definitely the biggest advocate for any AMS program. And they are also, for this program particularly, they are the source of truth about that antibiotic allergy history. So that consumer engagement lens is really important. What we found with this project, and I think this applies to all AMS programs, is choosing your target patient population is really important. So I think sometimes with AMS programs, we pick the target group who we have the best relationship with. And for this program in particular, that ended up being GenMed. Unfortunately, a lot of GenMed patients are not appropriate for an oral challenge. Getting an allergy history is difficult. It wasn't a great place to start with this project. And we really encourage teams to start with surgical units because those patients have a shorter length of stay, generally can give you a great antibiotic allergy history, generally quite well post-op. You have the opportunity to oral challenge them. But I think this is a lesson that you could take away to all AMS programs, like really picking your target group is such an important step. Multidisciplinary. AMS teams do this really well, but it's something that I think we just need to acknowledge and remember is a strength of AMS programs throughout Victoria. And it really, with our program, really highlighted the role of pharmacy, infectious diseases, and nursing all being on the same page and all being engaged in this program. Data. So really, when you're collecting data, is it meaningful? Do the clinicians see what they need to see from that data? So even if you think it's important, do the clinicians on the ground think it's important? It needs to be minimal burden, and assessing the ongoing need regularly is really important. So in terms of barriers and enablers that we learned from this program that could be applied to other AMS programs, so education, so making sure you've got appropriate education lined up. As I said, multidisciplinary, it needs to be multidisciplinary. You need multidisciplinary governance and engagement in these programs. The consumer voice is very important, and it can really help promote your program and can also help strengthen your program. And then selecting the right patient population is a huge enabler. Our barriers, which I haven't really touched on, was so governance at hospitals, particularly with our program, were quite risk averse. So really think, you know, if any program you're rolling out, any AMS program, if there is risk averse governance, we got sites to start really small. We got sites to start, you know, in patients that you could probably directly delabel, they would oral challenge those patients. And just to get their oral challenge numbers up and make their hospital feel, you know, that they have safety netted this, they've got their systems down pat, and that they know what to do in this situation. As I mentioned before, in Victoria, protocol development had to occur at every site. This was a very lengthy process. We did, you know, share resources, share protocols with all of the hospitals, but still getting through each hospital's governance took a very long time. The time, so how much time do you want sites to be involved in this project for? I think you need to be realistic about that when you're setting up these AMS initiatives. I haven't touched on this, but my health record. So my health record is a big thing. Yeah. It's something that we are looking at, we are advocating for at the moment, along with a lot of other organisations. And then another barrier is paper-based systems. And look, we have some great success stories with paper-based systems, but it is that added layer and challenge when we're still looking at a lot of our regional hospitals that are still using paper-based systems. So what's next from a check again perspective? So we are continuing to recruit Victorian Health Services. If anybody would love to come on board, we would love to have you. Please reach out to me and we can discuss that. We still are talking to my health record. It is a slow process, but it's definitely something that I think is worth it in the long term. We are talking more and more about forcing functions. How do we force clinicians to do what we want them to do? And how do we do that, particularly with hospitals that have electronic medical records in place? And then we're also still looking at developing other models of care. So we have a very variable healthcare service system in Victoria, and each hospital does need to set up their own model of care. And so we're still looking at what other models of care would be helpful for our clinicians. So if you want to contact us, please email 100,000 lives at safercare.vic.gov.au. There's heaps of information on our website. I'm always happy to have a chat if you would like more information about this program. I just had, I wanted to acknowledge we have a lot of people that have contributed throughout the lifespan of this program. And without it, without their ongoing support and engagement, we definitely wouldn't be where we are today. And I just wanted to highlight all of them because, yeah, we're really appreciative of their ongoing support. Now, I did have a slide for questions, if anybody has any. Yeah.
So does anyone have a question for Misha or anything about the program?
I
Great, Misha. And I just for everyone to recognise the global leadership that this Jason and Misha and Elise and the team have been, this work is extraordinary and rapidly scaling. Just for everyone's interest, what was a characteristic of a site that was an early adopter versus a late adopter? And there are particular flavours of people who were resistant.
So I think so when we look at the collaborative, the sites that were early adopters were, you had that really engaged champion. We actually felt rural and regional sites, if they had that champion, could actually get their program off the ground quite quickly. They could get their protocols approved quite quickly. For them, and I asked them about this, for them it was because governance to them was a knock on the door, like a knock on the office next door and saying, look, we've got this program, can you help support us? So you really needed, so I would say the people who did well were those people that had those local champions who were super engaged. I also think rural regional sites have less complexities in terms of governance than big metropolitan sites. So that was definitely a huge enabler for success for those sites.
We found exactly the same with the sepsis scaling, where we were able to rapidly implement the sepsis program in a rural regional sites for exactly that reason, the knock on the door. And I think one of the important parts of this program, which is really important, is that we've empowered a whole lot of people that weren't previously empowered.
Mm-hmm.
Just like in sepsis, we want the nurse initiation because they're the coordinators of care. The same thing here. And Belinda's in the audience, aren't you? Where are you? Is Belinda in the audience, Lambros?
Yeah.
Did you want to comment from a nurse practitioner perspective for nursing roles? Introducing Belinda. So she works with us at Peter Mac, and she's the first APRA accredited nurse practitioner in stewardship and infection. She does stewardship, skin prick delabelling, runs clinics, sees patients, manages sepsis. She's pretty amazing, but it would be really good to hear from you about your experience in this.
Thanks, Kaz. So I guess I'm very fortunate in that Jason Triviano was my mentor throughout this whole process and recognised how important nurses were in this role. We are at the bedside with the patients. Often doctors will come in and have a chat and some of the stuff goes over the head. And so engaging those nurses who are able to answer those questions and translate is really important. And I think engaging them is sort of the success of what we've had.
Any other comments or questions before we talk? Okay. Well, good. Thank you, Misha. Okay, so our final talk for this morning session before we break for morning tea is Dr. Kylie McIntosh, who's the Principal Policy Advisor for Medicines and Safer Care Victoria, and is a particular interest in antimicrobial resistance and stewardship, and represents Victoria on the Australian Commission on Safety and Quality in Healthcare, Service Medication Expert Advisory Group, and Antimicrobial Stewardship Jurisdictional Network. And thank you so much, Kylie.
Thanks very much, Rod. Lovely. Look, unlike Misha, I'm not actually a specialist AMS pharmacist. I do, however, as Rod just mentioned, have a long-standing interest in antimicrobial resistance and stewardship. And I still remember coming back from maternity leave in 2011 and speaking to the director of the branch in which I worked in the Department of Health at the time. So this was the Quality and Safety branch. And the director said to me, we would like you to look into this area of antimicrobial stewardship. We think it's going to become really important. And two of the very first people that I met in terms of external specialists in that area was, of course, Kaz Thursky and Kirsty Busing, and had this really interesting conversation around the work that needed to be done in terms of addressing resistance and the establishment of antimicrobial stewardship. So in the years that followed, I have to say it's been absolutely fabulous to see the establishment of AMS programs in Australia. So from the mandatory requirement for health services to have an AMS program in place since 2013, which really helped to prompt a lot of activity in that area, to the work in terms of the NAPS development, and then the establishment of NCAS and just the brilliant work that has come out of NCAS. So just wanting to acknowledge that, and also the support and advice that we have always received from the department, and also more recently through the establishment of Safer Care Victoria and that ongoing advice, where if there's anything that we want to know or require some assistance or advice with, it's like, Kaz, you know, can we please have a chat? So really just wanting to express the appreciation for that. So AMS is a well-established area for pharmacists in the hospital setting. In community, however, this is a more recent development. And in Victoria in the last couple of years, this has come to the fore in terms of what does this look like in community because of the advent of the community pharmacist prescribing pilot in Victoria. So what I'd like to run through now is firstly how that all started in terms of an election commitment back in 2022, to talk to a couple of elements in terms of the pharmacist prescribing. So what are the models of prescribing and what does that look like for the state pilot? An overview of the development of the Victorian pilot, touch on training and education, both for the pilot, but also opportunities and where we're heading in terms of AMS for undergraduate pharmacists and for community pharmacists. Literature review, which was released a couple of months ago now, which was the first of its kind, as I understand, looking at the quality of pharmacist-led UTI management protocols across the country. So this is what's been happening in Victoria. So what does that look like in the other states and territories? And then briefly some next steps. So an election commitment. So back in November 2022, we had then Premier Daniel Andrews announcing that the government would support a community pharmacist statewide pilot, and this was intended to be a 12-month pilot to test an expanded role for community pharmacists to treat a number of what were considered low-risk health conditions, including uncomplicated UTIs in women, reissuing selected oral contraceptive pills, and treatment of some mild skin conditions. There's also a component where there would be an expanded authorisation for participating Victorian pharmacist immunisers to administer additional travel and public health vaccines. And there was some significant funding attached to that. So almost $20 million was announced in the 2023-24 state budget. The Premier did continue to take a particular interest in the pilot throughout the time, and it was interesting. There are a number of social media posts where, so what's he said this time? And there was one time which gave us all a bit of a fright when he got the date for implementation. I'm like, no, we're not going to be ready by then. So a few interesting moments in that. And the pilot actually did commence back on time in October 2023. And there was some substantial legislative changes that were required as well. So it was certainly a very busy legal team within the Department of Health to ensure that those changes got through the Parliament and then were gazetted in terms of the Secretary approval associated with that. Having announced that one of the health conditions to be included within the pilot, however, in terms of the UTI, and there would be then a role for pharmacists to be prescribing or providing antimicrobials where these were indicated to women. Of course, it raised that flag of, but we need to be really cautious in terms of the development of the program and ensuring that this adheres to the best principles of antimicrobial stewardship. So the aim of the pilot more broadly was to ensure that the community would have improved access to selected primary healthcare. And there was a focus particularly around women's health. So, UTIs in women and also the oral contraceptive pill. So that focus on really improving women's health. Saving money. We continue to be in a cost of living crisis. So that the intention was that there would be no financial barrier for Victorians to access services under the pilot, so that consumers would receive this service. They would not pay for the consultation as such, and any out-of-pocket costs for medicines would be the same as if they had received the antimicrobials through their GP for a prescription in the usual way. In terms of community pharmacy as a setting, the understanding that community pharmacists are accessible, that they are trusted health professionals by the public, and they already do manage a range of health conditions and are quite used to referring consumers on to a doctor where required. There was also the intention to strengthen the primary healthcare system, noting that there have been significant workforce constraints. So the intent was to help ease pressure on general practice, on hospitals, and with particular regard to rural and regional areas. So briefly around pharmacist prescribing. So what is that and what does it look like and what are the different models? It is interesting to note that our state legislation on drugs, poisons and controlled substances, so the Act, which has been in place since 1981, actually doesn't provide us with any definition of what prescribing is. We do know that for a number of years now, there are other non-medical prescribers who operate in Victoria. So for example, nurse practitioners, podiatrists, optometrists, nurse and pharmacist immunisers, and there's all sorts of weird and wonderful little ones, including ski patrol. So who knew that? But as in just selected analgesics for trauma on the ski field. There are actually three models of non-medical prescribing, and this was defined by the Health Professionals Prescribing Pathway back in 2013. So the first and the one that people are probably most familiar with is autonomous prescribing. So that's where your prescriber does undertake that prescribing process within their scope of practice and without the approval or supervision of another health professional, and that prescriber is also educated and authorised to autonomously prescribe in a specific area of clinical practice. So GPs, this is a standard practice for doctors. The second is prescribing under supervision. So where that prescriber undertakes prescribing within, again, their scope of practice, but that is then under the supervision of another authorised health professional. And the third, which is what has been used within the community pharmacist statewide pilot, is prescribing through a structured prescribing arrangement. And this is where a prescriber who has limited authorisation to prescribe medicines by legislation, so the DPCS Act in Victoria, requirements of a national board, and also policies of the jurisdiction or a health service. They can prescribe medicines under a guideline or a protocol, which is what we employed in this instance, or a standing order. So just in terms of comparisons, so structured prescribing or prescribing by protocol is already within the scope of a registered pharmacist. Autonomous prescribing is not within the scope of registered pharmacists currently. The training in terms of structured prescribing can be relatively short and specific to particular treatment protocols, as is the case in this instance. Autonomous prescribing, the training that is required is quite extensive, typically a master's degree, and that is something that is being looked at in Queensland in terms of pharmacists being upskilled to become autonomous prescribers. It's not something that Victoria is looking at, certainly not at the moment. Scope of prescribing is relatively narrow. in terms of that structured prescribing, whereas autonomous prescribing, obviously that scope is quite broad. Collaboration with other healthcare professionals is required in both, and there are a couple of examples that we've included here. So obviously with the Queensland, which was one of the first pilots to take place in the country with that community pharmacist prescribing, but also now the current Victorian pilot in terms of the UTI management. So just an overview of how did we build the governance, the project overall. So this was a really big undertaking to put together within 12 months, as I said, particularly around the timelines for ensuring that that legislation would both be ready and then would be passed through the Parliament. But also the clinical side in terms of that development of the clinical management protocols. So what that looked like within the department, so there was an executive sponsor being the Director of Primary, Community and Oral Health within the Department of Health, who would report through to the senior exec, who would then, I haven't included the minister here, but that should be reporting up to the minister, who was very interested in seeing the project develop and unfold. There was a project control group that would then report to the executive sponsor. So within the project control group, for example, the Safer Care Victoria CEO sat within that group. Sitting under the project control group was the Department of Health working group. There are a number of representatives of Safer Care Victoria that sat on that working group. There was also a pilot coordination team that put together all of the work that fed into that. So sitting off to the side and reporting through to the working group was a project advisory group, which contained also a number of external stakeholders, and then a clinical reference group, which I've highlighted here in purple. And the clinical reference group was convened and supported by Safer Care Victoria. And that was to really build in that and ensure that clinical safety and quality lens, and that included considerations of antimicrobial stewardship. I would also say off to the other side here, there were a number of different teams within the department that contributed to the delivery of this project. So I haven't included here, for example, the legal team, there's a communications team, a specific evaluation unit looking at this, and of course the IT platforms, and also that procurement of external providers of training programs to be developed and delivered alongside the program. So that clinical quality and safety component, as I mentioned, Safer Care convened the clinical reference group, which met quite regularly in the early days, so as frequently as every fortnight, given the very short timelines that we had to deliver this project. And the group provided that expert clinical quality and safety advice, supporting the design and also through the early implementation phase of the pilot. And we needed to ensure that the group contained appropriate and suitable expertise for covering all of the selected health conditions. So remembering also that there was a focus on women's health, so ensuring that we had women's health practitioners. So we're also including pharmacists as well through the key professional organisations, also pharmacists in the community, including business owners, GPs, also including a GP who specialises in antimicrobial stewardship, a number of ID physicians, public health physicians, clinical pharmacologists, and also representation from the therapeutic guidelines as well. Our approach to protocols, guidelines and training was intended to be broadly consistent with other initiatives that were happening or starting to happen in other jurisdictions. And it was an interesting time given that these were happening at the same or similar time. And there were at one stage meetings between all the different jurisdictions, more just sharing updates and experiences, challenges, barriers and enablers and that sort of thing every month or so with the leads from all of the other states and territories who were either thinking about doing, or implementing one of these programs down the track or in the process of doing this. As I mentioned, the clinical management protocols were to be developed based on current best practice guidelines. So in particular, calling out antimicrobial, antibiotic prescribing according to the therapeutic guidelines. Also the training. So I mentioned that there were several providers that were engaged to develop the pharmacist training modules for use in the pilot. So what did that look like? So I did mention the involvement of therapeutic guidelines and the fact that the antimicrobial recommendations and indeed the approach to the management of UTIs by the protocol would be consistent with the guidelines. So first-line therapy is not actually antimicrobial therapy, as you would know, so it is conservative management, and that was made really clear through the protocol as well. So conservative management, treatment of symptoms, and with the understanding that if those symptoms should not improve within the following 48 hours, that consumers could then return to their community pharmacy for consideration for antibiotics. And the antibiotics, and again, thinking this is prescribing via protocol, the only antibiotics that were made available for pharmacists to be able to prescribe were literally trimethoprim, nitrofurantoin, and cefalexin. So in that order, with should antimicrobials be required, trimethoprim as first choice. So there was no scope for pharmacists to sort of say, well, actually, what about amoxicillin, whatever else? No. Okay, so that wasn't actually within the protocol. So there was that understanding. Also following the, in terms of the exact recommendations of the guidelines, so trimethoprim, 300 milligrams daily for 3 days, which meant in community pharmacy providing broken packs. So we actually had to go through that process within the department of what does that look like, and potentially compensating community pharmacists for that, breaking of standard antibiotic sizes and packs, which different considerations compared to hospital pharmacy. So within the protocol really steps community pharmacists through understanding patients' needs. So community pharmacies who were participating in the service, and I'm not really sort of going through it within this presentation, but there was also quite a process. So community pharmacies did need to put in an expression of interest. They needed to be approved to participate in the pilot and demonstrate that they had both completed a number of requirements, so including the training at that point, but also that their premises were suitable and that they also offered a private individual consulting area within the pharmacy to ensure that patient privacy concerns. So there are a number of other considerations with this as well, but I'm not going to go into that too much within this presentation. So during that consultation process, the pharmacists were then required to step through a number of different questions and to understand the symptoms, the history for the patient in front of them. And in terms of the patient eligibility, so obviously this was only for women of a certain age range between 18 and 65. For patients who were considered, sorry, just to go back, so this is a traffic light system within the protocol. Patients with either complex needs or, for example, showing signs of a more serious infection such as pyelonephritis needed to be referred on to either a GP or emergency department, potentially in terms of pyelonephritis, and that the pharmacist could provide general health advice where this is appropriate, but not to supply antibiotics. Patients with additional needs or where that differential diagnosis was not clear, patients were then to be referred also on to a GP for management. So again, pharmacists could provide the general health advice, but antibiotics not to be supplied. And finally, patients that were considered to be low risk, that a patient could prescribe as per the structured protocol only. Again, first-line treatment being conservative management, but then pharmacists were able to actually prescribe and supply antibiotics as appropriate. So whether that's trimethoprim, nitrofurantoin, and cefalexin. And while I'm not able to actually share data from the pilot today, there was my understanding is there's a very high level of pharmacists sticking to the protocol and prescribing trimethoprim in the first instance in the vast majority of cases. So another part of the project was obviously a really important piece in terms of that communication and engagement. So firstly with the sector, so sector communications to ensure that awareness of what the initiative was about and also that engagement in implementation. So we held a couple of webinars early on, just as the project was getting started. The expression of interest was out there and there were hundreds of applications from pharmacies, which was really exciting. So I think pharmacists were ready to take this step to look at extending that scope of practice and to be involved in this. So in Victoria, I believe we have around about 1,500 to 1,600 community pharmacies. And at this stage in the pilot, we have over half of those pharmacies offering the services. So about 800 are currently enrolled as participants in the pilot. So the Department of Health website hosts a lot of information, both for the sector and the community. So all the resources that are required for pharmacists, so including the different clinical management protocols for the different conditions, and also materials for pharmacies to promote the service, the various services, I should say, including management of UTI. So in terms of the communication out there to the Victorian community, so there are a number of public communications so that the public would understand what is the scope and also the purpose of the pilot, and that they're aware of the participating services. So a really important part that is associated with that webpage is a map. So look for the pharmacy nearest to you. And there was actually, or there is, I should say, good coverage in terms of community pharmacies in rural and regional areas who have signed up to the pilot. There are media releases, including social media posts. So I talked about the Premier, former Premier was very excited about this particular project, also the current Premier, I should say, but I think Mr. Andrews very much enjoyed his social media posting on various things. Consumer information leaflets, there's information on the Better Health channel. I would say, and this is something through the development of the project within Safer Care, AMS was certainly very carefully considered by us in terms of that development of the clinical management protocol. But if you look at the poster that was first developed by the comms team, which we hadn't seen, the pink one over here, so community pharmacist pilot, new healthcare services available here. When we saw that poster, like, you can't use that. We can't be putting out to the public, come and get your antibiotics here. That's not how it works. So there was that understanding that actually this is really important, not only to educate the public, but even our broader team who weren't healthcare clinicians, they're comms people, and they had looked at the project and like, oh, this is what we need to get out there. Patients can't currently access antibiotics from community pharmacies, therefore we'll put that information out there. And like, no, that's not good antimicrobial stewardship. We need to talk about management of UTIs. We're not going to be talking about, yes, come in and get your antibiotics. That's not what we want to happen. So that poster there on the left was the later version. So the pharmacist training for the community pharmacies who were involved in this. So before pharmacies could actually commence providing the services, they were required to demonstrate that they had completed the appropriate training programs. There were two that were developed. So there were also some existing training modules that were available both through the Pharmaceutical Society, but also the Australasian College of Pharmacy. But these were adapted for use within the current program. So these needed to be completed by any pharmacists who were going to offer this service. So by all of the pharmacists within each of the participating pharmacies. One thing I just wanted to touch on too, so there were queries, particularly early on in the project, but concerns, as you can imagine, from different healthcare professions saying, but wait a minute, pharmacists don't really have the training to deliver programs, particularly where antibiotics were going to be prescribed and supplied, and concerns about, but aren't we going to be worsening, antimicrobial resistance by having more prescribers out there providing antibiotics. I mean, we do know that all pharmacists have a role in AMS, whether that's in hospitals, aged care homes, or the community. And as I mentioned earlier on, pharmacist role within hospitals is pretty well established when it comes to AMS, but less so in the community. And just noting this article that NCAS put out just a couple of years ago, so this was 2021, where you looked at AMS by Australian community pharmacists, and what was the uptake at that time? How did pharmacists feel in terms of feeling knowledgeable and empowered and confident enough to participate in AMS initiatives, and even contacting GPs to query antimicrobial prescribing. And in the conclusion of that article, just noting that pharmacists did feel that they had some limited training and resources to conduct AMS activities. So I think there's certainly scope for improvement, but having said where that fits into the current pilot, and noting that within that structured prescribing arrangement, a protocol-based arrangement, that was a reasonable course of action, I think, in terms of prescribing via protocol. It's easy just to point to, relatively easy to point to that and say that this would provide some safety around antimicrobial use in the pilot. In terms of other training opportunities for community pharmacists in AMS, so there are various other courses that have started to come out. Obviously, we have fantastic events like this to provide upskilling for pharmacists, but also the PSA has been putting out more training courses. So there quite recently new training modules to support quality use of medicine services, including, so this is in terms of residential aged care facilities. So there has been a new module put out recently in terms of the AMS, which is good to see. But what about our next generation of pharmacists? So just wondering where we're at, and I contacted Monash Uni just to see now what's happening now, and this is also Misha as well. How are we going in terms of, have there been changes made to the undergraduate course to ensure that our new pharmacists coming through the undergraduate courses have an awareness of AMS and some training in AMS as well? And so introduced in 2019, so looking 5 years ago now, there is a particular unit within the undergraduate course now around that comprehensive care, pathogens, host defence and treatment, where this particular unit provides knowledge and skills required, management of patients with selected infectious diseases, covering off on various infections, as well as antimicrobial stewardship and the detail that falls under that, which is fantastic. And also understanding from the academic who is leading that area within Monash Uni, Angelina Lim, who you'll see is one of the authors of the article referred to on the right there, that she is also trying to undertake various research projects and for undergraduates to participate in those. So this article and the study arose from a project that fourth year students were undertaking. So really trying to develop that awareness and understanding of AMS in community pharmacy, and to look at what are the opportunities for community pharmacists going forward within AMS. I mentioned that a couple of months ago now there was a review published which looked at community pharmacist-led UTI management programs or protocols. And this was looking at protocols and UTI management services that have been introduced around the world. So looking at the United Kingdom, Canada, the US, New Zealand and Australia. And we were quite interested to see this come out because our protocol was included there as well as one of the protocols that was looked at. And so the intent of this review, and it's a grey literature review, so our Victorian clinical management protocol for UTI management has not been published in a peer-reviewed journal. So, and that's the case as well, I think, for the other pharmacist prescribing programs around the country. So the objectives of this particular review were to look at and identify the protocols for the community pharmacist management of UTIs in women, to outline what were the key components of the protocols and also to look at the quality of those protocols. So the age range of the women, so I should say the Victorian protocol actually allowed for women in the age range of 18 to 65, but pretty similar here. I should also note that these were clinical management protocols in the English language as well, and where they identified protocols that met the definition of a clinical management protocol as well. So through the study, they identified a total of 274 protocols and 40 were actually included in this final review. There were 10 key components of those clinical management protocols that were identified, which I've listed here. And overall, 36 of the 40 protocols that were evaluated contained at least 5 of those components. The Victorian protocol contained 8 components. The last 2 highlighted in red there are the 2 which it considered that we didn't contain. The Victorian team did look at including dipstick testing, but decided against it. It's some of the comments made within the review. So they did note that there was not sufficient reporting on the stakeholder involvement within the protocols that they could see published on the net. It doesn't mean that it didn't happen, but it just meant that we didn't actually articulate that in the protocols, and that's including the involvement of consumers, that the rigour of development was not articulated in those protocols, and that there was also an insufficient provision of implementation information and also a failure to declare editorial independence. So for their conclusions from that study, and I would say they scored all the different protocols, and we did score a pass, which was nice, but they came to the conclusion that a standardised clinical management protocol for community pharmacist-led management of UTIs could be used to optimise practice in the area, and noted that while there were a large number of clinical management protocols available for pharmacist-led UTI management, but the content and the quality of those protocols really varied. It was interesting too, just to see the dates at which each of those protocols had been published. So there was a real flurry of activity in recent years, a lot being published in recent years, but the oldest one actually came from the US, and that was back in 2011. So that was the earliest one that I could see there that had been developed. They did also note that to reduce that fragmentation of primary care and in order to enhance patient health outcomes, that consistency between protocols needs to be prioritised. And that's just noting in terms of that consistency between protocols brings me to the next point here, that what does that look like in terms of Australia-wide? And just within the last couple of months, we can now say that every state and territory in Australia now has in operation a community pharmacist prescribing initiative. All of those do contain a UTI management service where pharmacists are able to prescribe antimicrobials. So having said that, we now have this service. And so is it kind of the same? But in fact, they're different as well in terms of both the structure of the program. So in Victoria, it's a pilot. New South Wales, and the ACT was included within the New South Wales initiative where it was run as a clinical trial. WA, for example, like, look, we're not going to go down the path of a pilot or a clinical trial. We're just going to make it a program. just put it into place, and it's an ongoing program, and then tweak it as needed as they go along. Pretty much all bar one of the states and territories are have been following the therapeutic guidelines recommendations for antimicrobials, except Western Australia, which due to local resistance patterns, so the consideration of their clinical advisory group for WA, didn't want to see cefalexin used due to concerns about local resistance. And in fact, they made their first line nitrofurantoin and second line trimethoprim. So that was the only sort of exception, if you like, across the country. But the clinical protocols different between the states. The training is now largely going to be harmonised. So there were differences within the training programs, but in recent times there's been discussions and there will be a consistent training program across the country, obviously with WA understanding that the antimicrobial recommendations are different there. So what are the gaps and opportunities and the next steps in the community pharmacist prescribing space? So as I just mentioned, we need to look at that harmonisation of the prescribing initiatives across the states and territories. So training, yes, but also clinical management protocols. What might that look like? Also the IT platforms, which I didn't really touch on within this. It is looking like the prescribing programs will continue and expand, and given the evolution of the programs that are happening both interstate and overseas, and looking at this in the context of healthcare costs to consumers, access, and also workforce challenges and constraints that are leading the development of these programs. So other health conditions that have been considered or included elsewhere, so looking at treatment of infection, impetigo, acute otitis media, acute otitis externa, where obviously antibiotics to be prescribed. At this stage, Victoria is not currently considering these particular conditions, but they are in Queensland at this point in time. Also looking at monitoring and management of chronic disease conditions as other parts of these programs. In terms of AMS perspectives, sorry, just realising the time here, I think it will be really important going forward to ensure that there is best practice in antimicrobial stewardship in any of these health services that are provided through the community pharmacist prescribing programs, to look at the appropriateness of the treatment decisions being made. I don't know whether we're going to see a CP NAPS, but we'll see years down the track. Patient outcomes, I think it will also be important to ensure the availability of that prescribing data to contribute to national surveillance efforts. So I think that has been a gap. And there'll also be ongoing improvement efforts required, and including that ongoing professional development for community pharmacists. So as I mentioned, our undergraduates coming through are certainly getting some much improved and some fantastic grounding in antimicrobial stewardship, but how do we also continue to support community pharmacists out there? And just briefly, an update on the pilot, so where we're at now. There is a formal evaluation that is continuing. There was an announcement last month that the pilot is to be extended up until the end of June 2025. That formal evaluation is intended to be available early in 2025. Future directions are sort of yet to be decided, but there is work ongoing at the moment in looking at different health conditions that may be included in the future. In terms of the services provided and the uptake by consumers in Victoria. So at the halfway mark, this is from a media release a number of months ago now from the Minister, there were over 10,000 services delivered. So these services have been well taken up by the public, including over 5,000 services for the treatment of UTI. Thank you. I'm sorry for keeping you from morning tea.
Thank you, Kylie. And I want to thank all four of our speakers, so Kaz, Norelle, Misha and Kylie. I think it was a very excellent morning session.